Some of us wish we were here to go home this week. Welcome y'all here today. I was asked to kind of give y'all a little heads up and background on FluoroVac systems, chest tubes, those kind of things. I'm sure most of you had some experience with them. We do maybe 10 to a dozen here a year. Seems like they come in waves. We'll do 2 or 3 together, and then we won't have it for a while. And after that period of time, everybody's scrambling, trying to find out what we need, how to do it, how to take care of it. So hopefully this will kind of give you a baseline to work on. We can kind of reinforce things as they come on. They're very simple. But to kind of get us up to the actual how do you take care of it, how you put it in, you have to understand the whole concept behind it, okay? As we all know, the lungs live in a cavity called the thorax. The thorax is a fixed cavity, okay? The reason the lungs expand is because there's negative pressure. When the diaphragm goes in, it creates a negative pressure, air comes in. Air usually stays in the lungs, right? It doesn't go out into the chest cavity. The problem is when the air gets into the chest cavity. When the air is going from the lungs into the chest cavity, you're creating this change in pressure. As the air goes out around the lungs, which is what we call a pneumothorax, it can actually cause the lung to compress, okay? And probably the worst condition is what we call a tension pneumothorax, when the air outside the lung, inside the chest cavity gets so great that it collapses the lung and can cause a life-threatening problem, okay? So if you kind of have that concept, that's one of the first indications for a chest tube. The other indication, which we see occasionally here, is for either blood in the chest, pus in the chest, fluid of some sort in the chest. Okay, it's not air, but it can cause the same kind of a problem. It can compress the lung. Okay, when we're trained in charity, every night we have somebody come in, shot, stab. Everybody got a chest tube. Okay, and it was just automatic reflex first thing you did. Okay, we don't see too much of that here, but that's an indication that we see. One thing we do see here occasionally is blunt trauma, somebody falling off a horse, getting kicked by a horse, MVAs where the ribs fracture, and as the ribs fracture, they have sharp points, they poke into the lung, boom, you get a pneumothorax or hemothorax. Okay, those are kind of the most common things we see here. Also we see fairly commonly what we call spontaneous pneumothorax, okay? Same principles happen, except there's nobody stuck anything in them, they haven't fallen. What happens in these people, they have usually a bleb disease that occurs usually on the top of the lung, where the lung tissue gets real thin and it spontaneously ruptures, okay? I guarantee you see these people, they're going to be tall, thin, smokers. That's the most common stereotypic type of patient you're going to see, okay? And these people usually present shortness of breath because of that decreased lung volume, okay? So in our patient population, that kind of gives you an overview of why we put them in, okay? Most of the time, it's not really a real life-threatening condition, except with tension pneumothorax, okay? In that case, if you've ever seen one, it's dramatic when you release the air, okay? You hear a big gush come out and so forth, okay? So you have kind of a concept of why we put them in. Very, I like things fairly simple. You got a problem, you put it in, it fixes it. This is one of those situations, okay? And we'll look at some of the subtleties that sometimes that's not true. This is a bedside procedure, okay? We don't have to take them down to OR. If you're compassionate or you catch me, particularly on a good day, I'll give you some sedation, or the patient some sedation. But we do it a lot of times without sedation, particularly in the ER. Man, we just boom, we numb it up, make a cut, and stick it in. It takes about 10 minutes to do. Okay, it can be that quick, or most patients, if you got time, will benefit from sedation. Okay, so when we do that, so on the floor, you got to go through all the sedation protocol and all that. You have to have a monitor and so forth. Okay, so I tend to like to use sedation when time allows. They passed out a handout. It's kind of a generic handout, but it gives you a good idea of what we use. We have kits on the floor that have all the instruments, usually just hemostats, Kelly clamps, needle holders, very basic instruments. There's some other things on there we use, scalpels, lidocaine, dressing material, those kind of things. What I use particularly is an Ezaki Might not fit this exactly, but this would get you by, okay? What I will ask the nurses to do when I get ready to do one, of course, we have to get consent. That's one thing I'll ask you to do. And the other thing is to set up the Pleurovac system, which I think scares most people, okay? And this is really very simple, okay? Don't let it frighten you because it's really very simple, okay? There's different kind of symptoms, systems. This just so happens to be the type we use here. It's called Pleurovac. There's smaller ones, there's bigger ones. In the old days, you might see little bottles that are connected, you know. We don't use those at charity, I think. But basically, the systems have 2 chambers or 3 chambers that you worry about, okay? One is the collection chamber. This is the collection chamber on this side, okay? It's gradiated, and what it does, it collects how much fluid comes out, okay? So when you put it in the tube and you got the system going, you'll see this fill up over time. It's good. Well, we need to know how much fluid is collected. I like to use shifts or for 24-hour period, okay? Sometimes this means something, sometimes it doesn't. Particularly when it means something if you have somebody that's had a chest tube placed because of trauma. If you have a large amount of output, say over 200 cc's of blood per hour, okay, that's not a good thing because they can bleed to death in front of you, and that might indicate they need to have their chest open to stop the bleeding. So it is important in some instances, okay? We don't see that very often here, but there are some cases. It's important when we go to pull the tube out. For instance, if you have a lot of fluid coming out, particularly in somebody that might have a cancer that's secreting a lot of fluid in their chest, you don't want to pull it out before the fluid has gotten to a level where it's not going to reaccumulate, okay? So if it's real high, you know, I use about 50 cc's a day or higher as being too high to pull out the tube. You're just going to want to leave it in a little bit longer. If it continues to put out, there are some things that we do, we call pleurodesis, where we can put some chemicals in the lung or in the pleural cavity to try to get that fluid to start slowing down, okay, before we pull the tube. So that is why it's important to record how much comes out. And do it, everybody needs to do it the same. It's hard for us to come in and say, well, one shift had this much. I like 24-hour periods, okay? Now, obviously, if they're putting out more in an 8-hour shift, I need to know that, but 24-hour periods, like for other eyes and nose, is what I really kind of go by, okay? They have 2 other chambers. I'm going to talk about the little chamber, or the red chamber here, okay? This is called the water seal chamber, okay? Now, this probably is more confusing. These 2 chambers probably more confusing than everything else, okay? What does it do? Well, the water seal chamber tells us, or lets us know if there is a persistent air leak, okay? Again, going back to what I described as far as the mechanism of, let's say, pneumothorax, if air is leaking outside of the lung into the chest cavity, it's going through the mouth into the trachea, out into the chest cavity, this right here will let you know, okay, because it will bubble. If any of you seen me come in and check a tube, I will pinch off the suction and have the patient cough, do a Valsalva, do something to increase the pressure in the lungs to see if this will bubble, okay? Because if this is bubbling, you cannot take out a chest tube. Let's think about it. You take out the chest tube, this is bubbling, there's still an air leak, you're going to have another pneumothorax, okay? So that's what this chamber allows you to identify, okay? It also, sometimes it's real hard to, or sometimes it can be very subtle. You have to really get them to strain real hard and things like that. So sometimes it's easy to determine, sometimes it's a little more subtle. So that's the red chamber, or what I call the water seal chamber. Bigger chamber is the, actually controls how much suction you're putting on chest tube. Again, we're creating or recreating that negative pressure in the chest, okay? Now what a lot of people don't understand is they think you control the suction up on the wall, okay? You got the little device up there and you can put it on max or intermittent on whatever rating you want. That does not control the suction. This is where the suction is controlled, right here, okay? Normally it's about, I use 20 centimeters, which is very easy. That's where most people use because there's a line right here. You can go up, you can go down. There's some very subtle situations, again, that you would make some differences there, but generically, 20 centimeters is about what everybody uses, okay? The only thing that the suction on the wall does, it has to be great enough to cause this to bubble. Okay, if it doesn't bubble, you're not providing whatever water column of suction you have in here, okay? It can be on max, all you're doing is 20, and it'll be bubbling, 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 or it can just be barely bubbling. That's all you need for this to do. Create a negative pressure, okay? Occasionally, if you have a tube in long enough, this will, and the bubble is real high, you'll have to add a little fluid. You know, if you get 20 and a half, it's not the end of the world, okay? You don't have to start over and trash the system, okay? If any of you have ever seen a chest tube, this is what they look like. They come in different sizes, okay? Some of them come with a trocar inside them. A trocar is a stiff thing that helps you put it in. Pass that around. They're all about the same length. They have a series of holes on the end. They're different sizes, kind of for different purposes. The smaller ones are usually all that is required for air, obviously, okay? You're not pulling out fluid. So we use the smaller ones, 20 to 24, 26, somewhere like that, for air. The larger ones, I like the biggest you can get for somebody with trauma, which is about the 40. I mean, they're pretty good size. An average is about 30, 32, something like that. So I use probably 32s, 26s more often than not around here, okay? Now, they never have those, so I might use a 34 or 24, But it really doesn't matter. The size doesn't matter to a great degree. Before we get the system set up, as I told you, before I come in and put it in, I want the system to be set up, okay? Or at least know how to set it up. That's the important part. And it's very simple. I mean, as I said, try to put too much thinking into this, okay? The easiest thing to do is this long tube goes to the patient, okay? This cap will come off and go to the patient, okay? You don't have to do anything with this, all right? So that eliminates that. Otherwise, you have, as I mentioned, these two containers over here have to have something done with them, okay? They have to have water put in them, okay? Doesn't matter what kind of water, if it's saline or sterile water. And to do so, it's very simple. Y'all know what this is. It's a fancy funnel. That's all it is, okay? That's all its purpose. And unless you're really good and can pour directly into that, you have to use a funnel, okay? And this will take care of the water seal chamber, okay? And as you know, as I put it in, it will turn blue, okay? Now, I can't tell you exactly how much it takes, probably about 20 cc, but there's a line on here that you'll have to come up and see. And that's generally how much we want to have in there, okay? It doesn't take much. So we just pour this in. Voila. That's pretty tough, okay? That takes care of that. That's all you got to do. On the other one, there is a top here, okay? Pop that off. It's a bigger hole. I usually freehand this one. This is the one you go up to 20 centimeters. Get way over or way under, there's a little plastic diaphragm here that you can take it out with a syringe. That's pretty close. It's set up, it's ready to go. That's it, okay? On the bottom, you might not notice, there's a little thing right here that lets you stand it up, okay? Do not try to stand it up on its own, it won't happen, okay? There's also some little hooks on some of these. Right here, you can hook it on the bed, all right? If this thing gets turned over, then you gotta start over, because it all gets mixed up and emptied out and so forth. Some people will take this to the floor to keep the stand up. It's just whatever you feel safe with, but it doesn't need to be turned over, because particularly in this will all get messed up over here, and you won't know how much fluid you have, okay? After it's set up, we put the chest tube in. We do this under sterile technique. There's different places to put the chest tube as far as positioning the ribs. We do go between the ribs into the chest. And I will usually suture the tube in a way that I don't use Vaseline gauze very much. Some people do, and if you read some of these things, they'll say gauze. Again, what you're trying to do is create an airtight seal around the tube. I use a purse string suture. The reason I do that, one, it creates that seal, and two, when I take out the tube, I don't have to put gauze in, it's got a suture ready and so forth. So there's just, again, different ways of doing it, and that's the way I do it. One of the things that I do is you have to secure the tube to the suction, okay? To do this, I'll put it together. I'm going to pick the small tube. And I will take these together. And of course, we know what the reason for that is, so it doesn't come apart, okay? I do that end, I do this end. I also put tape on the patient where it will not pull on the tube, okay? Because you don't want this tube to back up. If you've noticed on these tubes, there is holes right here. If this hole backs up to the skin, you've lost your system and it will leak air, okay? So you don't want this tube backing up eventually. And then when you do x-rays, you can kind of see where this last hole is. But occasionally this will back up and you won't even see the hole, but the patient will start getting the subcutaneous emphysema where they start kind of getting a Rice Krispie feel to them and all that. And sometimes this is a reason, the cause of that. Okay. Tubes stay in again for a varying degree of time. Usually for a pneumothorax, if the air leak stops, 48 hours is kind of an average time. Sometimes we get somebody with a persistent bleb, it just won't stop. There's some little maneuvers I do to try to get it to stop. Occasionally those people won't stop and they'll have to be taken to surgery, and that bleb will have to be surgically removed. Okay, but most people will spontaneously stop from a bleb, a hole in the bleb. Again, when people have it for other reasons, how much drainage dictates when it comes out. Okay. When we pull them out, they're very simple. I usually let y'all get involved because I'm tying the suture, and I'll let y'all pull it out. Usually we have the patient again create a Valsalva maneuver, take a deep breath, hold it, because what you don't want them to do is to inhale while you take it out, because they'll suck air into the hole. So I'll explain that, count to 3, have them take a deep breath. They hold it, and I'll usually have the nurse pull it out real quick. Don't just pull it out real quick, and I'll tie down the suture and I'll tell them to breathe. Okay, it's very simple coming out. Okay. Now, things that you don't want to do. These things come with a little clamp right here. I don't know why they come with this thing. They ought to be thrown away, in my opinion. You do not want to clamp anywhere on this tube. Okay? Why do you think that's important?
Because if you clamp it, you're going to drop them probably into a spontaneous
If you
pneumonia.
have an air leak, let's say you have an air leak on this side. If you clamp here, there's no system preventing you from getting a tension pneumothorax. Okay? So anything you do here takes out this system. Okay? If a patient's on water seal and you have the system here, there's no way they can get a tension pneumothorax unless this is clogged up or something, okay? Because the air pressure will come and it'll bubble through the system. But if they have an air leak and you clamp anywhere up here, the air has nowhere to go in the chest and it will just build up and cause a potential tension pneumothorax. So never, in my opinion, clamp here unless very specific orders are given. There is a time that I will clamp here. It's in that patient who may or may not have an air leak. I'm not real sure. They might get a bubble every now and then here. I just don't feel that I can determine if they have an air leak. And in those situations, I will tell the nurse to clamp this, okay? But always I give specific instructions. If they start having shortness of breath, notice their breath sounds decrease, they have any distress, you unclamp it. okay? Because that will release any tension that they have. If, the ideal is if they have a very small air leak, we'll know it, okay? If they don't have an air leak when it's clamped, and they don't get a pneumothorax, then the tube is ready to come out. So that's probably the only indication I will have for clamping. It's very unusual. I have done that before. So, very simple system. Don't be intimidated by it. There's really not anything you can do wrong except clamp the tube, and I don't tell you, and all that. And let's say what if? Let's say you're making rounds and the tube has come apart. Okay, this has come undone. I didn't tape it or whatever, and it's just in the breeze, flying in the breeze, so to speak. Don't panic, okay? As long as the tube is in the patient and it's uncovered, they're not going to get a tension pneumothorax, okay? The pressure in the chest is equal to the pressure in the outside. You'll hear air coming in and out. It's not an emergency. Just clamp it back up, okay? That's all you got to do. And put them back on suction, okay? So don't panic. As long as you have that free movement of air, you're okay. A controlled pneumothorax is much better than a tension pneumothorax. Okay. Any specific questions I haven't touched on? Some of y'all have been there with me when I put them in might say there's something I haven't said or something, but very simple system. It's easy to take care of. Don't be intimidated by it. Something that we use enough where we need to know about them.